Please be sure to complete the sign-in sheet. Commissioners are seated around the table. Thank you so much for everyone joining us online. Thanks for everyone that was able to make it here in person. Our distinguished guests and work group members, you can sit around the corners of the room. We have meeting materials printed. Please, if you haven't grabbed, just make sure you grab copies. Our commission remains grateful for the Baltimore County Health Department for hosting us and, always providing us with refreshments. Thank you so much. My name is Oluwatosin Olateju. I am the presiding co-chair for today's meeting. Welcome to the April 2024 meeting of the Commission on Public Health. I'm joined here by Dr. Boris Lushniak, and we also have Dr. Mina Brewster on the call. They will be assisting with facilitating with the flow of the meeting today. I'm also joined by our support staff. We have Chidubem Egbeluchi here from Morgan State University, and we have Michelle from University of Maryland. Thank you. Thank you both. This is a hybrid public meeting, and we appreciate, once again, we appreciate everyone. We followed the requirements for posting the meeting in advance, okay? And the information can be found online. We would continue to do that in accordance with the law. If you want to access the information, just make sure you visit our website. And for people that may not be familiar, it's smchd.org/Commission on Public Health. Also follow us on our LinkedIn page to stay abreast with all our activities. So this meeting is being video recorded, okay? And by your continued participation, you're consenting to being recorded. In the interest of time, I just want to note that our meeting roll call and discussion items, including questions and comments, will focus mainly on the commissioners. I kindly ask that commissioners please identify themselves when speaking or asking questions or giving comments so that those in the room and those online can know who is speaking. Unfortunately, we are not going to be able to do a formal roll call. As you can see, our time is advancing. We won't be able to do formal roll call for non-commissioned work group members. But please note that, we value all, your contributions, we value your presence, online and in person, and we want you to have the opportunity to sign in. So if you're joining online, make sure you type your name in the chat box. Also type your group, your work group affiliation information so we have it. We'll not be monitoring the chat box for questions and comments. However, we strongly encourage that you please share your questions with us. And you can also direct your questions and comments to our general email, which is md.coph@maryland.gov. If time permits, we'll be very, very happy, probably during the presentation or at some point as other work group members present. If time permits, we'll be very happy to take questions, right, or comments from our non-commissioner work group members, okay? But if you do not get your questions answered, I'm apologizing ahead of time. Please, again, send those questions to us via email. So I will now ask Chidubem to please conduct a roll call of the commissioners. Thank you.
Thank you, Dr. Dawson. Please, if I call your name and you're a commissioner and you're here, please, you can say present or you say here. And I'll be going on with the roll call. And I'm still, if you're on the Zoom, you can say on Google Meet, you can still say present or here so that we can take note of that. And we have Chris Brandt, Nina Brewster.
Here, thank you.
Okay. Thank you.
Jane Drummond.
Yes, I'm right here.
Thank you. Ariana Kelly. Boris Rushnak.
Here.
Oluwatosin Olateju.
I'm present.
Francis Phillips. Nicole Rochester.
Here.
Mura Rosman.
Okay.
I'm present, thank you.
Richard Spencer. Allian Twig.
Here.
Okay. Heather Bagnell. Nalish Naraman. Elisa Lord. Elisa Lord. Camille Blackford. Thank you.
Okay, so I just want to check that, we have a quorum. Do we have a quorum, children?
Yeah, we
1,
do.
2, 3, 4, 5, 6,
Yeah,
7,
we
8, 9, 10. Okay, we have 10, yes. So for the record, we have a quorum. Thank you. So next is the adoption of the agenda. Commissioners that are present here online or online, the agenda for the meeting has been posted on our website. We also distributed the materials via email. So take your time to just glance through. I'll now entertain a motion to approve the agenda. Nicole, thank you, Nicole. All right. And then, can I get a second, please? Oh, Nilesh, okay, thank you. Okay. All right, thank you. Thank you. So Nicole moved and Nilesh seconded. All right, thank you. Are there any, questions, about the agenda or any discussions about it? All right. If there be none, all in favor, and they were also glancing online, I don't see any, oh, and Camille Blake Fall is here. Just you can mark her present. Yeah, thank you. I see it, Camille. Welcome. So all in favor, please say aye. Aye, okay. All right, thank you. Any
Aye.
nays or, yeah, thank you. Any nays or abstentions? I think Jane, were you saying something? Your mic is,
No, my mic is, I'm
okay,
good.
sorry. Yeah, got it. All right, thank you. So I don't see any, dissent in the chat box. It looks like it's unanimous. Yeah, thank you so much. The motion is approved to, adopt the agenda. So moving on to the minutes, review. Okay, here we can go to the next slide, please. Thank you so much. I think you have to share on the screen here, if you
Yes,
don't
sir.
mind. Yeah,
Absolutely.
sorry that you're not able to see it online. Let's share it on this computer. Give us a minute. Let's make sure we pull it up. It's sharing on the biggest screen in the room. Technical, yeah, it's not showing up. Thank you.
Just to note, Tosin, of course, all the meeting materials that were submitted before the meeting, I think were posted to the website as well. So if people want to see.
Right, right. Yeah, thank you. All right, I'm just gonna keep going along. Just in the interest of our time, we'll continue with the next item on the agenda, which is March 7 minutes review. I'll direct your attention to the minutes. It's in your packet, and for those online, you have it. I'd like to call for a motion to approve the March minutes, and we'll entertain a discussion afterwards. Okay. And it's being shared on the screen now. Apologies for the technical difficulties.
So moved.
And then make sure we share that. Can we get a thumbs up if you can see the slides advanced? Want to reduce it so you can monitor the chat box? Thank you. See, can you reduce the screen a little bit? Let's see, 1 second.
Let me share it a different way.
Okay, hold on 1 second. We just want to share because of the members of the public that are attending. That way they can also see the slides. All right, so are there any comments about the minutes? Commissioner, no? Okay, all right.
Motion to approve.
Okay, 1 second. See here. All right, so thank you, Mina, for moving. Do we have a second? Okay,
Second.
thank you. Michelle seconded. All right, you have that up. Screen there. Right. Are you able to minimize that so you can monitor the screen? Yep, there we go. Technology would will always show it. So sorry about that. All righty. So thank you, Mina, for the motion, and thank you, Michelle, for the second. All right. Okay, moving along the minutes. So let's take votes now. All in favor, please say aye. Aye. Okay, thank you. Are there any nays or any abstentions? Abstain? Okay. All right. So Michelle, I'm sorry, Nilesh is abstaining. All right. Great. The minute has been approved. Thank you. So now it's time for special guests. I just wanted to note that we have some special guests amongst us. We have Shane joining us online. Shane is with the CDC Foundation. I'll have him introduce himself in a second. We also have we have another special guest. I'm not gonna give the person's name off. Boris will be introducing him in a second. But Shane, if you don't mind, if you can introduce yourself briefly, would appreciate that. And Shane after. Thank you, Shane.
Thank you, Tosin. Hi, my name is Shane Hatchett. As Tosin mentioned, I am working with the CDC Foundation to support the Maryland Commission on Public Health. I've spent the last month or so getting up to speed on where things are, and really excited to work with you folks on this project. For a little bit of reference, I most recently was the Deputy Health Commissioner and Chief of Staff at the Indiana Department of Health. And in that role, I helped lead our Governor's Public Health Commission through a much similar process as you're undergoing. So have some experience and lessons learned that I can bring to bear here, and really excited and looking forward to getting the recommendations put forward, the report adopted and submitted to the legislature. Thank you.
Thank you. We're so happy to have Shane as a member of our team. Thank you, Shane. The next item is the presentation, but we'll give it a few minutes for our guest presenter. We're just waiting for him to be with us. So what we're gonna do is we're gonna skip, right? We'll skip the presentation and we'll get but we're right on time, right? With regards to the where we are on the agenda. So let's talk about old business, right? Let's talk about old business. And again, we'll go back to the presentation from our guest speaker. So I'll have Mina, please, go right along with old business. Thank you, Mina.
Sure, thank you. As we identified at the prior meeting, we have 5 regional public listening sessions planned in Maryland. The details of that are being worked out. We're hopeful that we can communicate out all the information in the next week or two for the commission. The first one, though, is coming up. That will be the one hosted in Southern Maryland. So the Southern Maryland Regional Public Listening Session for the commission will be on April 16th, which is a Tuesday, at 5:15 in the evening at the St. Mary's County Government Center in the County Commissioners Meeting Room. And the information and details, address, et cetera, for that will be on the Commission on Public Health website. After that, there are dates throughout the next handful of months where the different jurisdictions are hosting the public listening session for their region, including Howard County, Montgomery County, Washington County, and Talbot County. So all those dates and ways to participate in person or to view the proceeding online will be made available on our commission website. And I believe many of you may have the dates already through prior communications. Thank you.
Thank you, Mina. All righty. Next, regarding business, we're going to go to new business. We have none on the agenda. However, there is something that recently came up. I'm going to have Boris talk about that,
So
and it's regarding House Bill 133.
Yeah, thank you, Tosin. I
Sure.
just want to inform the commission that we were just informed by Wes Queen, who's one of the staff members present here from the University of Maryland, who's our person monitoring work in Annapolis. Thank you, Wes, for being part of our team. Wes, just for the record, also runs our Legacy Leaders Program, which in essence trains individuals who are in their retirement years to staff and play a role in state government. And so This is sponsored by the University of Maryland School of Public Health. Wes is the main instructor and coordinator of that program that gets individuals who are ready for that second or third career to be both advocates as well as assisters or assistants within the government in Annapolis. So thank you, Wes, for doing that. That being said, we've been informed by Wes that this afternoon the Senate has passed a bill which the House had passed last week, which is House Bill 1333. And the important aspects of that bill is this is a tag on to a bill that deals with the Health Services Cost Review Commission. But this is a request that we had put forward to several of our delegates and senator friends, Senator Ariana Kelly and Delegate Jocelyn Pena-Melnick, to assist us in terms of dealing with the issue that we started with on our first meeting, which is what's the timeline of this commission. And so now officially the timeline is that the changes to the initial bill that established this commission have in fact taken place. The timeline now is that on December 1st, 2024, we shall provide an interim report of our findings and recommendations to the governor in accordance to the state government article, the Senate Budget and Taxation Committee, et cetera, et cetera. So an interim report from us. And the way we look at that interim report of this will be both a process that has gone on over the course of the year, but also any preliminary data that we want to share with the governor and other delegated authorities. And perhaps if we're at a point of interim recommendations, then we will put those into the interim report. Notice the timing of the December 1st report is in front of just before the next legislative session, 2025, which then provides any recommendations or information to both the Senate and to the House of Delegates and to the governor about what's going on with public health. So that's point number one. Point number two is that our final report is now put in with a timeline of October 1st, 2025. So this gives us the time that we had requested. Once again, this provides a nice time period of the report then to be circulated and provided for action with the legislative calendar in 2026. The last segment is that obviously that initially the commission itself was supposed to sundown in June of 2024 and actually June of 2025.
Right.
And now that's been extended to June of 2026. So that gives us the requisite time. Obviously, if our work is done, we'll continue doing some peripheral work, but this gives us a whole lot more of breathing space. And I know so many of the commissioners are like, well, I didn't sign up for this time period. Okay. Don't bring that up here. And do not bring that up. Do not bring that up here and now. Okay. My point, I think, as a commissioner, a fellow commissioner, but also as one of the co-chairs, is this at least gives us that breathing space. And remember how we were so concerned at the beginning that we're just going to rush through it, and at the end that the product is not going to be what we all wanted. I believe strongly with this support from our senator and from our delegates that this will in fact give us a little bit of breathing space as we promulgate this information to our working groups. The big factor here is it's not that we stop any of our work now, okay? So we don't want to sort of the aura to be, okay, well, we got all this extra time, so let's all take a few months off, right? But it does, I admit, depressurize Tosin's viewpoint on this. It depressurizes Mina's viewpoint on this and my viewpoint as co-chairs. I know when we talk with our co-chairs of our working groups, it does depressurize their timetable, and I hope for the rest of the commissioners. I'm not asking you right now to sign up for the full time period. We'll get to that later. So we're not saying that, you know, there's a time to rotate off in the midst of all this. We're convinced that we can do this job, do it in an efficient manner, but at least this gives us the requisite time. So, Tosin, that's all I have to report in terms of new business, but I think this is good news, huh?
Thank you so much. Thank you. Thank you, Boris. Great, thank you. Now, looks like we're just, it's great timing. We have our guest here. We have Dr. Josh here. Thank you so much. I'm gonna have Boris, please do the
Great.
introduction.
Well,
Thank
we're
you.
certainly pleased to welcome Dr. Josh Sharkey here to our commission meeting. And Josh, these are the commissioners. We do have a quorum here today, both online as well as here in the room. Dr. Sharkey, he's the Vice Dean for Public Health Practice and Community Engagement at the Johns Hopkins Bloomberg School of Public Health. He's also Director of the Bloomberg American Health Initiative and Professor of the Practice in Health Policy and Management. He's also served in multiple positions, leadership positions in public health, both at the state and the federal level, including the Secretary of the Maryland Department of Health and Mental Hygiene at that time, the Principal Deputy Commissioner of the U.S. Food and Drug Administration, Commissioner of Health for Baltimore City, and as a health policy advisor for Congressman Henry Waxman. He's also an elected member of the National Academy of Medicine, the National Academy of Public Administration. You know, I always say when I know people, there's always a personal angle to my introductions. So Josh and I first probably met, although I knew of him beforehand, in 2009. He came into FDA as the Principal Deputy Commissioner in the midst of the pandemic that we've all forgotten, the H1N1 pandemic of 2009, 2010. I was then the Assistant Commissioner for Counterterrorism and Policy and Planning, also running the Office of Counterterrorism and Emerging Threats. And I was the Deputy lead on our pandemic response, the Deputy Incident Commander. And all of a sudden, in the midst of this new guy walks in. And at first, you know, much like anything else, we're in the midst of this battle against this pandemic, which ultimately was a real pandemic. We'll remind you of that, but obviously not quite the one that we were waiting for. That one came a decade later in the midst of coronavirus. But I remember getting to know you in the midst of a crisis and getting to know your leadership style and the ability for you to sort of just come in and then, in essence, get it caught up to speed very quickly. I was discussing with Nilesh and Fran about Josh, is that he has the uncanny ability to be super busy. Even now, he had a Zoom call. He's here at all time. There's a million things going on his plate. And yet he's always the most calm individual in the midst of all these. So I'm not sure how he handles that. But I'm pleased to announce to our group the presentation for Dr. Josh.
Great.
Thank you so much for the introduction.
Excellent. Thank you. And Boris, I think we met maybe 6 or 7 years before that when you were at NIOSH.
Oh, yeah.
And I was
right,
on
actually,
Capitol
yeah.
Hill. Yeah. So
Mhm.
we go back, I think, 20 years.
Yeah. And you were on the hill at that point. Yep.
Yeah. All right. So I'm talking today about public health and healthcare in Maryland. And I am now the chair of the HSCRC in the state. So I have a few things to say based on from that perspective. I think that was partly what might be
Right.
helpful, and a little bit
Yeah.
about ahead as well. All right. So now who is controlling the slides?
Yeah, it's
Oh,
been approved.
you're doing,
Yeah.
okay, perfect. Sorry, I thought I was doing it. All right, perfect. So, anyway, I know that probably people have a different starting place. It's great to see everybody here. So I'm gonna, give a little bit of background information before jumping to some of the, more, current topics, but just to say Maryland is unique in the country. Maryland sets the rates for all of the hospitals. That's for every payer, from Medicaid to Care First, and Medicare, and that's been going on for decades. And so that's sort of a very unique system. We're the only state with this kind of rate regulation system. I used to say one way to think about it is that Medicare pays Medicare rates in 49 states in the District of Columbia and everywhere else. And in Maryland, Medicare pays Maryland rates. So Maryland is very unique in its ability to control the spending for hospitals. Next slide. So these are the questions that I'm going to go through. What is hospital global budgeting? How does the HSCRC incentivize innovative models of care? I thought that was an interesting and related topic for public health. How does the HSCRC support public health? How does the HSCRC work towards health equity today? What is ahead, and what are opportunities for convergence between the Maryland model of healthcare that the HSCRC is very involved in and public health? That's really the question we're driving to through these. Next slide. What is hospital global budgeting? Very briefly, next slide. This is, just really important to understand when you think about public health, that everywhere else where hospitals are paid fee for service, you have to have a sick person to get paid. In Maryland, you don't anymore need to have a sick person to get paid. The hospitals get a budget. And if fewer sick people come in, particularly because the hospital and their partners are working to prevent illness, then the hospital keeps the money. It's really the only state like this. And I think at a very high level, it aligns the incentives in healthcare much more for public health than the incentives that exist in the rest of the country. One way to think about this is if, for example, an older person doesn't fall in New York, then 100% of the savings go back to the federal government, right? New York doesn't keep any of that money. But if an older person doesn't fall in Maryland, that money that would have been spent for the hip fracture and everything else, that money actually stays in Maryland. At least the acute care spending stays in Maryland. Actually, all the Medicare spending now does. So you can actually think about, well, why don't we take some of that money and invest it in preventing falls, if that would make sense. So the incentives are fundamentally different in how the budgets are constructed. Next slide. So in theory, what does this mean for patients? Hospitals are reimbursed based on the population they serve, not the number of services provided. Hospitals should be trying to help patients stay healthy and stay out of the hospital. One of the hospitals, when they switched to a global budget, and right now all of our hospitals are on global budgets, said, one of the CEOs said to me that our old motto was, "We're here for you always," and our new unofficial motto is, "We hope to never see you again." And we are going to try to keep you healthy and out of the hospital. And I said, well, what does that mean? And he said, well, we now give appointments, not just phone numbers. We give the medicines, not just the prescriptions. We have 24-hour social work in the emergency department, and over time, hospitals have done a number of things to try to coordinate care better in order to, and do other things in order to keep people healthier. Next slide. These are some of the strategies, and they include better care coordination, more multidisciplinary care teams, the use of data analytics, particularly from CRISP, and different kinds of strategies working with doctors. Next slide. And on top of that general idea, the HSCRC specifically disincentivizes what it calls potentially avoidable utilization, EAU. And that is, think of that as like a child with an ER visit or an admission for asthma that could have been prevented, or a skin infection that could have been taken care of at an early stage. So it really does need hospital care, but it could have been prevented if there were good care. And so the hospitals are not, are particularly disincentivized for these particular kind of admissions as well as readmissions. There are incentives for them to reduce these, and that leads them to be thinking about how to prevent and to do better financially when those types of admissions are actually prevented. Next slide. All right, so those are some of the basics of hospital global budgeting and how it's supposed to work. Within that, the HSCRC tries to incentivize innovative models of care. Now, I'm going to talk about how things are, not necessarily how much better things could be. And I think that's going to be where we're going to wind up, like how we could work together to get things better. Next slide. So I'll tell you, I thought I understood a lot about the HSCRC. When I became chair, I learned a lot of the details. One of the details that's pretty interesting is the Care Transformation Initiative program. And this is a project undertaken by a hospital or a group of hospitals to reduce the total cost of care of a population And that could be a geographic population. So you're starting to get closer to public health. You could say, here's something, a hospital could say, here's what I'm going to do to reduce asthma in this population at a geographic level, or this is what we want to do to reduce heart failure readmissions at this geographic level. And you sign up for it. And then there's a baseline of savings or costs that would be expected for that population. And if you beat that, then you get the credits. And if you don't beat that, there are no penalty. Okay. And so hospitals now have signed up for these on a bunch of different topics, but I don't think they're very widely appreciated in the public health world, because there's opportunities to say, hey, let's work together. Let's sign up for one of these. Let's work together on a project. And then if there's savings, that savings will come to the hospital. Now, there are a couple asterisks here. Right now, these are essentially only Medicare, only for Medicare. So it's not all payer. And the other asterisk that people point out is this is overall net neutral, meaning that if a hospital gets money, they're getting it from all the other hospitals. So they're sort of like the hospitals that don't have CTI savings have to pay into a fund that goes to the hospitals that do get CTI savings. So that was created as an incentive for hospitals to want to do more because they don't want to be outcompeted by the other hospitals. So at any rate, this is a kind of interesting financing structure that exists within the global budgeting regimen to encourage collaboration to reduce the cost of care and improve health for discrete populations, including geographic populations. It could be all patients with sickle cell anemia in the state of Maryland. There are multiple ways that you could define these. But I do think one of the limitations, we'll talk about it, is that it's not all payer right now. Next slide. There are other kinds of incentives, just in general. The model is trying to get hospitals to do things differently. Here are a few other examples, like emergency department diversion programs, different kinds of coordination clinics, home visiting programs that have sprung up or been strengthened as a result of the shift to global budgeting. Next slide. So let's talk about population health for a minute. Next slide. This is just a little bit of basics, which is because we have a statewide system, we're able to take some funding from the healthcare system and use it for other things, including CRISP, which is largely exists because of the Maryland model, the funding it can get, the Maryland Healthcare Commission, as well as other programs, including workforce programs like nurse support. Next slide. And there are common population health investments that the HSCRC and the hospitals have agreed to over time, including the big effort in the Baltimore region to address behavioral health called GBRICS. There's efforts to help provide housing for people as well. And so there are occasionally moments when you can actually take money and put it towards a population health goal. Next. And some of you may know what is called the SIHIS, which is not what I consider an evocative acronym, but it is an acronym nonetheless. The Statewide Integrated Health Improvement Strategy, which was set a few years ago and aims to improve health in part by focusing on diabetes, opioids, and asthma and severe maternal morbidity. And so there have been different efforts under those auspices that the commission has invested in because of that state strategy that was set through the public health department. Next slide. So a couple things on health equity. Next slide. There are many different components to the commission's equity work. This is their slide on different projects that they work on. I just want to mention a couple. One on the next one. That Maryland has the best data on race ethnicity for acute care services and severe illness of any state in the country because of the work that the commission has done to make sure that hospitals give data that's correct to them. So that is a real great strength of Maryland's system. That also includes data on financial assistance. Next slide. And then the commission can do some and has done some pretty innovative things like in addition to incentivizing reductions in readmissions, the HSCRC gives extra bonus if you can reduce the disparity in readmissions at the same time. We're the only state in the country that does that. Next slide. And that is for all payers. So let's talk about AHEAD. All that is just sort of like a little bit of background that the commission, while it's primarily thought of as, setting the budgets for hospitals, is actually dips its toe in a number of issues that relate to the work of the commission. AHEAD is expected to be the umbrella CMS agreement that will allow Maryland to extend global budgeting and extend the model, okay, for another 5 to 10 years. So we're on the second iteration right now of global budgeting in Maryland. It started in 2014 when I was secretary. It was re-upped in 2018, and then this current round ends in 2026. But ahead of that, it's likely that Maryland will go to the AHEAD model. The AHEAD model is kind of based on Maryland, and so CMS is allowing other states to do some of the similar things that Maryland does. It includes goals for healthcare cost spending through hospital global budgets, a focus on improving population health, and a real focus on advancing health equity. They're the three elements on the right: hospitals having global budgets, a big investment in expectation in primary care, and a population health strategy to achieve health equity. So all that is going to be expected to Maryland over the next, few years if we're accepted into the AHEAD model. The state just applied to the AHEAD model. March 18th was the deadline. And so we should find out pretty soon if we're accepted. I wouldn't bet against Maryland at this point being accepted, but, and then we would have 12 to 18 months to build out what this vision would look like in Maryland. So it's a pretty ambitious effort by the federal government to basically start with where Maryland is, but then push a number of states towards greater population health and health equity. Next slide. This is the graphic from Maryland's application, which is now posted to the website. This is Maryland's vision under AHEAD. So it's got these different elements. I'll just say it includes aligning public and private investments towards common population health outcomes, enabling innovative models of care, more investments in primary care and behavioral health, and a whole pillar on promoting health equity through elevating community decision-making, identifying, addressing, and measuring health-related social needs, and investing in community capacity building. So if you go back one, it would say at the bottom, you can see that the health equity plan will be developed for the state. That's part of what CMS is expecting. And Maryland says that we'll elevate community voice to define our shared commitment to health, integrate and align resources across clinical and population health needs, and overcome systemic and structural racial and ethnic health inequities. So that is the vision for what Maryland will seek to do as put forward to CMS. And let me just say a couple quick things. I know there's plenty to talk about here on this. A few things to note in this proposal. One is that it really calls for multi-payer alignment, meaning not just Medicare. So I look at this and I think, something like the CTI program, it's a fair question. If we're going to create a new innovative model that could partner with public health, it should be for everyone, not just for Medicare patients. There may be new options for global budgets that is in the proposal. So other types of global budgets as they currently exist might be tinkered with. Doesn't say exactly how. There will be this Commission on Health Equity that will create a new Maryland Health Equity Plan that will be the overarching document for the work in the state. It mentions the creation of regional population health hubs to coordinate work with the hospitals out into population health. And the timeline is about 12 to 18 months of planning if and when Maryland is accepted into the AHEAD program, and then the new projects would be implemented. Next slide. All right, my last thought here. What are opportunities for convergence between the Maryland model and public health in this context? So here are 4 suggested topics here. One is data and analytics. There are just incredible data tools available now at the geographic level that can support public health and are supporting healthcare and can support healthcare. Falls, asthma, diabetes. I think this is just an enormous opportunity both for public health and healthcare to be looking at the same data and trying to identify points of intervention. You know, in theory, any health department, any map, you could look at what's happening on asthma with just a couple weeks of lag time. Maryland is unique and it can turn almost any problem into COVID level dashboards, you know, as long as the outcome is being seen within CRISP. Then you have, so the working together to develop tools that support orient both public health and healthcare to the same outcomes is a real possibility. The second, discrete population health initiatives. You know, there are populations of patients who face challenges where part of the answer is clinical care, part of the answer is in the public health toolbox. Multi-visit patients who come to the emergency department again and again. You know, some health departments have been involved in helping those patients already, but that kind of work could be scaled up because often what those patients need may be outside a typical clinical set of therapies. Asthma home visits would be another example, or other kinds of, even if you think of a discrete population where maybe there's a disconnect with the healthcare system, but public health could figure out a way to bridge that gap, maybe through the use of peers or community health workers or people with lived experience helping. So, you know, this would be under the umbrella of like there's a specific population that the public health toolbox and the healthcare toolbox would come together on. Then there's obviously, these are in no particular order here, system level engagement. The state health equity plan is obviously going to be extremely influential for under AHEAD. And so really engaging in the development there. And then there will be, you know, a lot of different things happening in primary care and what the expectations for primary care are in Maryland coming down the pike. And that's another area of engagement for, I think, public health. And then I also think that as the AHEAD model identifies key outcomes and goals and metrics, that there's a real opportunity to align public health to those as well, because they will be fundamentally population health outcomes. So it would be strange in my mind to have one set of outcomes for the hospitals and doctors to be working towards and a different set for public health departments to be working towards. The highest level, these should be things that really matter for the health of people in Maryland, and that may lead to some thoughts about how you can restructure public health. You know, I'll end with this, that you guys have a really important charge here. So I appreciate being invited. I probably just started with that. You have a really important charge, which is rethinking how the public health system can really serve Maryland into the next, you know, few decades, really. I don't think any kind of activity like you're engaged in has happened for decades. So who knows whether it'll happen in the next few decades. So this is like a chance to think big picture. What should public health be doing and how should we organize? And I think it's fair to say that generally speaking, public health is organized around specific activities that are funded rather around goals that are, you know, widely shared. And this is an opportunity to think about other ways of structuring and supporting public health. I hope this presentation is giving you a sense of where I think healthcare is kind of moving. But I think it's moving in a direction towards public health. Public health will have to move to meet it.
Yeah.
I don't think personally public health can stay where it is and expect healthcare to make it all the way over. You know, so it's sort of like, what is that synthesis? That's something that I think could be a pretty important topic. Thank you. I hope I've tried to keep it to 15, 20 minutes like you asked.
Oh, yeah, I mean,
Okay.
thank you. Thank you so much, Dr. Sharpton. What an insightful presentation. It really speaks to the amazing work that the Earth Service First Review Commission is doing. And it's so interesting. Was it last month we had a presentation from CRIP, so we can just see how everything is coming together. And like you said, it's time for, clinical care and public health, right? To start speaking the same language. And like you said, we have a charge ahead here. How can we be, that force, right? To bridge that gap. So with that said, just want to welcome questions or comments from people in the room and our commissioners online. Is there any?
We have two persons.
Two questions, okay.
Gentleman.
Jane, okay. Jane, please
Yeah.
go ahead.
Yeah, this was excellent, excellent, excellent. Thank you so much. Just when you
Yeah.
thought you knew a little something, can you hear me?
Yes.
Yeah,
Yeah.
yeah,
Yes.
yeah. Thank you so much. This was excellent, and to the chairs and all for bringing, this is awesome. I wanted to ask, what is your thought about utilizing the levers that we have around, our health plans, right? Our Medicaid health plans, and driving some of this. When I think about, so we work nationally in multiple states, and what I'm seeing in other states, and first of all, let me just say, Maryland's got it going on, right? We're small, love it, no question. Everybody's trying to be like us. We love it. We got Chris. I see, my colleagues. We got a lot of stuff going on. But also, I do see with other plans, other states, I see that other plans are required to not only write a health equity plan, but they're required to report on them quarterly and to really make sure that they are actionable, right? So everything from, the collection of real and social data to truly identifying where are their greatest disparities and developing culturally, humble programs that, are demonstrating results. And so in other states, that's kind of what I see. What is your thinking around, I know, we've had the TOC, we're waiting on now the AHEAD program. How do you see us utilizing the levers, which, a large percent of our funding goes into the health plans to advance this work, just out of curiosity?
Again, just to get my opinion here, I think that it's really important for the state to have a direction in health equity and for everything to kind of align to it. So I do think there should be expectations on health plans, but I don't think it should be that each health plan should go out and have its own approach to health equity so that they're all kind of jostling and competing with each other. It would be better if the state said, look, these are the things we want to accomplish. These are the key initiatives to accomplish it. And here's how we expect health plans to be able to participate in that.
Yeah. So I saw on your last slide, you mentioned a state health equity plan. Is that
Right.
something that you are recommending to have done? I had not seen that. That
is required by the AHEAD model. So
okay.
that is something that Maryland will have to do to be.
Okay, got
in
it.
the
Got
AHEAD
it.
model.
Got it.
It won't happen immediately, but it will be developed over the next year, for example.
Sure.
So
Sure,
I
sure.
think there's a really important role for health plans because they do, like just exactly for the reasons you said. But I think that, we should have a health equity plan that everybody can contribute to, and that it's very clear, how everybody is working towards the same direction.
Yes. Love it. Thank you so much. Thank you.
We have Mina.
Mina? Okay, please, Mina, go ahead.
Hi, Josh. Thank you so much for being here, and I really appreciate your presentation. My question is more about the regional population health hubs referenced in the AHEAD proposal. And if you could talk more about that. Obviously, I know this commission is going to be focused on looking at a variety of components relevant to the governmental public health infrastructure, including the state and local health departments. Part of the beauty of Maryland's public health system, I think, is that it does have local reflection through the local health departments. And because of the shared governance structure, the local health departments are able to reflect the needs and work towards addressing the needs in their local jurisdictions. Could you talk a little bit about the role of those regional population health hubs and how they may collaborate with our already established local public health infrastructure?
Thank you for the question, and I totally understand the importance. But I'm going to disappoint you a little in saying that I was not in the center of putting together the AHEAD application, and I can't really tell you more of what they have in mind. But I do think that they might say that it is not a fully defined concept yet. And I think there's an opportunity, and I would recommend that you talk to John Crom, Laura Herrera Scott, obviously, to, hear a little bit more and start a dialogue about what that is. I think you can understand that there are some functions that may make sense to be in every health department separately constituted, and some functions that really may make more sense to be more regional, based on the way that people go to the doctor and within healthcare. I think I would assume that these are population health hubs more in the patient population sense than in the geographic population sense, but that may not be 100% true. I think it's worth asking. And I think it's worth thinking about, what is the role, if that is true, that health departments can have or want to have in kind of a patient management kind of, programs, So if, there are a lot of excess readmissions for patients with heart failure. Patients with heart failure, if they don't get good care, don't have a nutrition plan, don't have access to food, don't have a scale they can weigh themselves on, which is really important to management, they're going to keep getting admitted. It's going to be very expensive and unnecessary and awful because they will be struggling to breathe every time they get admitted. So, you could imagine, I'm just making this up, you could imagine that a coherent effort to really support patients with heart failure who are getting admitted again and again, they're not that many, but they're very high risk of all kinds of bad outcomes, really makes sense. So then the question is, what's the role of public health in that? Is that something that is going to be, just a quasi-clinical program that's set up? Do the health departments want to be in the first position with that, or the second position to support a program like that exists? But I think kind of conceptualizing what is thinking through this is really what the healthcare system is going to be driving towards, keeping people with heart failure from getting admitted again and again and again. Well, what is our role in that? And that, I think, having thought through that, you can think about, what you think about the idea of a population health hub and the kind of work that it could do versus the health department. I don't know if that's, I'm not trying to, there's only so much I can say, but I do think it's a really important discussion to have. But you all thinking about the future of public health are going to have to think about what's the role of public health in this continuum, from the patient to the community. Where do you want to be impactful in the public health system of the future?
Thank you.
Yeah. Do we have any other person online before? I think Fran has, Dr. Polsky?
Yeah, Dr.
Dr. Polsky.
So,
Yeah, please go ahead.
Josh, first off, thank you very much. It was a great overview. You covered a whole lot of ground very quickly, and I think for everyone, explained it very nicely. I do have one question is whether it's under total cost of care, and I'm a little less clear about all the goals with AHEAD, but we're clearly shifting away from looking at just treating people in the hospital to keeping people healthier out in the community. And so from an HSCRC perspective, it's still, I'm wondering, to me, it still seems like the majority of the goals or programs that are mentioned are addressing people who are already very sick, and it's how to better manage them. Like you mentioned, you referenced people with congestive heart failure. From a public health standpoint, we oftentimes look at trying to prevent the problem in the first place. And so I guess my question is there room in AHEAD for true preventive? And I'm thinking things like childhood and adolescent obesity that do not move the needle for hospitals financially. But if we don't address those issues at this point, 20 years from now, 30 years from now, are we really any better off? And things like vaping, again, things that are earlier in life that are always starved for funding, are those areas that there's room for under the AHEAD model?
Yeah. So, thanks. That's a very good question. I think that, this sort of relates to the previous point that I made, which is that public health has to think about where on the prevention continuum you want to be. We have urgent secondary prevention needs. Like there are people who are sick, who keep getting admitted again and again. It's expensive. They die earlier as a result of the failure of secondary prevention. And, it's an imperative to improve that. We have a lot of people who have already crossed into illness, and there will be crossing into illness, and getting that right is just really important for the healthcare system. Primary prevention is also very important. And I think what I would say is there's no question it's under AHEAD, but because AHEAD is quite expansive in what it conceives of, but that doesn't necessarily mean that those are going to wind up being priorities for the HSCRC. I think that the HSCRC is very focused on the health outcomes as well as the total cost of care. That both of those are very important to what the state is expected to do. And so speculative investments or investments in things that we hope work that may pay off 20 or 30 years from now are probably not going to be they're easily funded out of the core operating health budget, whereas you could fund a number of prevention initiatives out of it. A foundational 20-year approach to childhood obesity wouldn't be my first choice, to be honest here, for that kind of funding to come out of operational health funds. But it doesn't mean that the state shouldn't do it, and it doesn't mean it can't be under the AHEAD umbrella, and it couldn't be an important priority in the health equity plan. It's just not likely to produce the returns to the healthcare system that source of funds is probably going to be expecting some level of, And so a better kind of investment would be something that builds capacity for longer term prevention while delivering something upfront to the healthcare system. So it doesn't mean that the HSCRC's world is irrelevant to primary prevention. It just means some of the ideas you would have would probably be more relevant than others. And that hopefully AHEAD will bring together health and healthcare in a way that there can be some priorities, and there will need to be some priorities that are longer term. And those are the ones that will need some of those will be the ones that will need different kinds of sources of funding if they're really going to get an investment. So I'm very hopeful that we can do different kinds of partnerships and investments in Maryland that go way beyond what other states do. But I'm also realistic that it's not just the wish list of through the healthcare system, the wish list of everything that we could imagine funding within public health. I hope that's helpful.
Thank
All
you.
right. Thanks.
We'll take a question from Fran. Can you close the computer over?
Thank you, Doc.
Hold on one second.
Okay.
Very good.
Oh, thank you.
So, just to put a little color on the example that you talked about with heart failure, because kind of serendipitously, I sit on the board now of a hospital that I'm seeing from the hospital's perspective what all this means as far as the incentives and the penalties and pushing in the population health. And I'm finding that absolutely there are potential crossovers. And let me give you a very concrete example. So in the hospital that on whose board I sit, the leading cause of readmission is sepsis. So people are coming back over and over, and they're really sick. And sepsis, when you drill down on these patients, as the hospital population health office has done to look at what zip codes they're coming from, what was their primary or the index diagnosis when they first came in. They have a zip code map of where the readmissions for sepsis are coming from. And the index diagnosis is pneumonia, right? So this is not rocket science, right? Well, none of them, according to Chris or the immunization registry, maybe that's one and the same, have had any bacterial pneumonia vaccinations, right? So there's this opportunity now. They know the zip codes where they've got very high risk people that have underlying chronic illnesses. Some of them don't, some of them are very healthy people, but nevertheless, to have a immunization campaign against bacterial pneumonia would have very broad and long-lasting consequences, but also for that particular population could avert readmissions for sepsis. So, I mean, that's just a very granular sort of example. Well, not to mention pneumonia, that of course, right, thank you. But here's, so here's the point. That is just because I happen to be sitting in the room and hearing about what this hospital is doing. And I'm sure every other hospital is doing similar kinds of things. And the public health people aren't in the room. And the hospital people aren't in the health departments. And so I'm on the governance and organization, as is Michelle, work group. The potential is enormous, but unless there's better communication and awareness across the sectors, it's going to be two different worlds. And I'm afraid that public health is going to miss out on some huge opportunities unless we figure out structurally how to embed ourselves into the planning process, into this now implementation phase. How do we do that? So that's sort of on us. That's on this commission to think about how we can make some structural recommendations. How can we do that? So
I think that's an amazing.
I'm not sure that's a question for Josh, but
I think that's an amazing opportunity for community health workers as well. I mean, and looking at the data in that kind of way, I mean, because community health workers can be that bridge. They're from the community, they understand, they know how to, to speak the language. And when you think about the cost of community health worker versus, readmissions and just the cost of quality of life, I mean, I think that workforce in and of itself can be a part of the solution that can bridge both public health and, this work that we're speaking of. Yeah, excellent.
Yeah, Fran, it's a great example. I would probably put this a little bit under the innovative models of care and partnership bucket a little bit, like for this specific example. I'm hoping, and I will be calling, I'll be letting the commission know and the health officers know, I'm hoping that the commission is going to be making different policy processes more open than they've been in the past. One of them may be brainstorming around different kinds of innovations that would make a difference, like that kind of thing. Another might be around the quality expectations that hospitals have, because mapping and looking at pneumovax deficits might be considered something that the hospital needs to do. Because what I would point out about what you said is, it's not just about pneumovax coverage. It's about the intersection of pneumovax coverage and pneumonia, and where the patient's coming from. And that you only know by really looking at hospital data. Now, you could take that to the public health system, and you could have an effort with Chris to map those two things. You don't need hospital approval to get crisp data and look at those overlapping maps and try to figure that out, and then potentially come to the healthcare system and come to the HSCRC and say, hey, look, this is something that we think that could be done, that would have an impact, and can we work together on that? I personally would be super excited for that kind of conversation. What could that be? And I can already think of a few different ways that could be structured. It could, in theory, believe it or not, be structured as a CTI, because a lot of those people would be in Medicare, right? So that could be a program where the health department works with the hospital, identifies the population, says we're going to reduce pneumonia admissions, and here's how we're going to do it. And if we actually do it, the hospital is going to get kicked back money afterwards. So there are different ways, but we won't be able to make progress unless we can show up at each other's doorstep with ideas
Yeah.
about what actually could work. And hope we're able to do that.
Thank you, George. I just have a statement. I think these are all like just great points. We have an opportunity here even to generate funding for public health. You know, if public health is included, there's an opportunity for bi-directional reimbursement, right? Just like how the hospitals are being reimbursed, public health, especially if we really leverage on some of the old programs and the new program as part of our ED's model. But as the total population health that has the diabetes, opioids, and maternal and childhood as focus. Again, these are all public health focus areas, right? So we don't have to really go big. We could start small, right? Looking at these areas and then again bringing the hospitals and public health together. Say, okay, how can we reimburse on both hands, right? How can the HSCRC
Right.
reimburse on both sides?
The hospital sees the issue as sepsis readmission of all
Yeah.
things, that wouldn't have predicted that, but the public health would just see it as pneumonia coverage rates. You know what I mean? But that
Yeah.
intersection is a spot where, it may be possible to liberate some resources to do targeted work together.
Sort of looks at zip codes, it doesn't stop at county or city borders. It's attributed lives. So hospitals often have multiple counties in their. So, again, some collaboration between local health departments.
Right.
Yeah. I think Nicole has a comment and then we'll take one from Boris. Right?
Yeah.
Or did yeah.
It's right along the lines of every single thing that has been said, so I'm like really excited. There's a clear thread. But it goes back to this idea of alignment or lack thereof, and some of the frustration that I've had as a physician, former clinician, now in these spaces is, so going back to the population health goals and CIHIS. And so if we just look at like diabetes as an example, there's this discordance that I see with regard to measurement. We have these measures that are readily available. So just as an example, the state chose BMI for diabetes. I'm not going to go into how problematic, there's lots of challenges with BMI and whether that's even a great measure, but it's easy enough, right, to capture that data as opposed to some other data. Similarly, if we look at like the maternal health crisis, we look at maternal mortality, maternal morbidity, we see that measures like infant birth weight and like prematurity, and there's other kind of proxy measures that don't really capture the root of the disparities and the root of the issues behind maternal mortality and maternal morbidity. But those are so much more granular and get to like provider bias and, quality of care and all these things that are much harder to measure and document on a population health level. So it seems like there's this disconnect between what's actually happening in the outpatient setting, in the inpatient setting, what's driving these outcomes that we're trying to improve versus what can we readily measure. And I don't know if you have any thoughts about that.
So I do, and I'm not really able to kind of defend or explain even how CIHIS measures were picked or implemented, but I do think this is similar to a question that comes up before the commission, which is even just for purely hospital issues, sometimes the outcome measurement alone is insufficient. What do you do then? And one of the things that we talk about at the commission meetings, and we actually had the head of IHI, the Institute for Healthcare Improvement, which is like this big national group, come and explain how he thinks about quality. And he really said that you just can't do it with just looking at the outcome numbers alone, that if you really need to have systems that build in quality, you need to, and part of that is, that you're doing the things to get to the right outcome, not just that you're somehow looking at the right outcome. And in part, that's an issue of measurement of the outcome, just like you're saying. So the implications of that are that you're not just saying, here's our one outcome, but here's the steps we expect to use to get there. And that's a concept that we're talking about right now at the commission around emergency department wait times too. That there's the emergency department wait time outcome, but then there are the kinds of things that hospitals could do that will be, better for emergency department wait times. We want to see those too. So if you have a theory for, well, this is what's driving maternal health problems, then you might say, well, we are going to look at these outcomes. Some of those are quite rare, but we want to eliminate them. But you can't just measure, run a quality improvement effort for a very rare outcome. It's very hard. You need to be thinking, well, what are the things that need to be done en route to that? And
Right.
you can measure those process issues, and then you can also have expectations for the kind of system that's in place that is going to be, dynamic and trying to figure out problems as they arise. The analogy that has always made sense to me, having worked at the Food and Drug Administration, is you don't figure out whether a drug is going to be, untainted just by testing samples at the drugstore. You have to work with the company to make sure it has a good quality production process too.
Right.
And when you do that, you really don't even need to test the samples at the drugstore. If they have a good quality production process, you're confident about that, but you can test at the drugstore, that's fine. But doing that alone won't work. And we have to have approach to our initiatives and quality improvement that has both of those concepts.
Josh, you know what? I so agree with you there. We're working with a health plan and looking at ROI, right? And when we think about, when you're just looking at the measure, that's not enough. But indeed, we're beginning to look at trust. So think about it. I mean, the very fact that this particular population may not have trusted the healthcare system. So for the fact that now they're willing to talk with you, they're willing to engage with you and listen, that is indeed in and of itself progress. It's a process measure. We're not there yet. Disparities did not happen overnight. Equity is not going to happen overnight. It's a process. And so I love that it's just that, but we haven't always honored, we kind of want to go straight to the number when we're talking about human-centered design requires that process. So love that conversation. Yeah.
So we'll take one more question from Boris, and then we'll take a break.
Yeah, so obviously, Josh, you got our juices flowing here. So thank you. This is really exciting.
Yeah.
And it is that intertwining, right? Which we have an opportunity now in these next, sort of iterations of this, of the recommendations that come from this commission, right? We're not going to be the implementers to change the world, but we need to make sure that, that healthcare and public health are in the same room. One of our advisors or one of our key sort of members of our leadership team is Dushanka Kleiman, right? Mm-hmm. She's on the line right now, but she sent in a question saying, are there more opportunities to align the primary care component of AHEAD and public health?
Yes. So
yes.
Mm-hmm. I think that there are going to be those opportunities. I can't speak. I think that would be a better question for both John and Laura to talk in specifics about. I will say that the commission, working with the department, was able to set aside some money to build new primary care in very underserved areas in Maryland. And we did a public comment period to get ideas for how that could be done. And some of the ideas came in were about community health workers and what a model of care that would really work in an area that has a lot of preventable disease, what that would look like. And so that, I think, is just a little taste of the kind of conversations that I would expect as the primary care investment questions come up under AHEAD. So I do think that is a really, that's why I put that up on my slide, the other slide of opportunities is engaging in the primary care plans. And just to end, Boris, thank you again for having me. Thank you, Tosin, for having me. Thank you, Mina, and all of the commissioners here. I think what you are doing is extraordinarily exciting. This is a moment of transformation of healthcare in Maryland. Look, I totally appreciate that to some extent we're following an Indiana playbook, but Indiana can't put its finger close to where we are in terms of our toolkit, support we have for public health and the opportunities for the healthcare system that exist in Maryland. And so, what you're doing is really going to be setting a new kind of standard for public health. And I think you should be thinking over the next 1 to 2 decades, and this is an opportunity to say, what is the public health system going to be doing? How's it going to be organized? What does it need to succeed? It's really exciting, and anything that I can do or the school can do to be helpful. I know you have Michelle Spencer here, and we have forwarded you some other supports, but please don't hesitate. Anything that I personally can do, I'd be happy to.
Thank you
do.
so much. This has been really, really awesome. If more questions come, the commission will be very happy to
Okay,
send them your
and
way.
I'll send you different
Yeah.
things
Yes.
that the other commission's up to,
That
and
would be
we
great.
can work on it. Thank you.
Thank you so much.
Thank you very much.
Thank you. We're now gonna take a break. Can you advance to the break line? Thank you. We'll take a 10 minutes break. It's now 3:30, 3:31. We'll come back at 3:41. Okay? Right, 10 minutes break. Thank you, everyone. Thank you so much. All right. All righty. The next item on the agenda, we're just waiting for the slide to be pulled up. This is another fun part. The work groups have put in a lot of work, within the last month. So we appreciate, everyone really, for their contributions. All right, we're just waiting for the slide to be advanced. All right, so welcome back once again. Right now, are there any general updates? The next item is general updates before we go into the work group presentations. Mina, Boris, or any of the work group pictures, any general? No? All right. Without further ado, we're going to have the communications and public engagement work group going, next for the presentation. But before we get into that, I just wanted to, just say that the presentations today are going to be focused on the work group data components and the collection process. So we're looking at the future here. We're thinking, what are the data components, right? And the collection process. What questions should we be thinking about, right? Across all the different work groups, right? Regarding survey questions, regarding questions, to stakeholders, regarding key informant interviews, focus group questions, and then just general thoughts for public listening sessions. So, all right, you have the floor. Communications and public engagement work group. Thank you.
All right, hello, everybody. So I'll be talking about the Communications and Public Engagement Work Group. Can everyone hear me well? Wonderful.
Yes.
All right, so I am one of the co-chairs. As you know, I co-chair this group with Dr. Tony Gedden, and I'm happy to share all of the work that our wonderful work group, and I want to say the word wonderful work group, has been doing over the past few months. And today I'm just going to share some of the questions that we believe are very important and in some of the realms that we're thinking it can be done. We can go to the next slide. I don't think I can control the slides from here, so can we go to the next slide, please?
Sorry, one second. Somebody's controlling it from the room.
Okay, sure.
Hold on one second. Thank you.
Okay.
Yeah, it's no longer from the computer.
Okay.
Next slide.
She got it. Thank you.
And if not, for the interest of time, I can continue talking.
I think it's up now.
Perfect.
All righty. Thank you.
Thank you so much. So as you can see here, we've been discussing who we want to engage, what are the roles that we want to include, and then I'm also going to share some sample questions. So we thought, of course, as of all of the work groups, that we want to engage the Maryland Department of Health and the local health departments. The roles that we'd like to have, the individuals, would be the communications and marketing staff. Now, just even saying communications and marketing staff should give us reason to pause, because as we may or may not be aware, in many of our local health departments, the individuals who are responsible for communications and marketing may differ. And so that is something that at first we'll want to clarify who is in charge of communications and marketing, find out who that is, and then begin to ask some of our questions. If there are no individuals who are in charge of communications and marketing, then we want to determine who actually contributes to communications and marketing related work in the health department. So that's something that we're keeping in the back of our minds, and knowing that that terminology may differ from health department to health department. And so either one, we're going to ask all of the health officers to tell us in advance who that is, or depending on what the mode of distribution of our surveys will be, having that person identify their role. Next slide, please. So here are some potential survey questions for our public health agencies. I'm not going to read them all for us. One, because this is being recorded and we can go back and check and the slides will be distributed, but I just want to give you a flavor of some of the questions. So what is important for us is that we find out a little bit more about the sources of information that our public health agencies are using when they're preparing public-facing health communications. Also, what communication tools are being used and the channels that are being used. And we want to know about the social media tools that are being used and how. So in terms of frequency and, who are the followers? Can they use that to kind of almost have that heat map? When we're talking about staff, do they formally train their staff, or are there certain criteria that the staff that's involved in communications has to have before they become involved in communications in their public health agency? And then also looking at, is it dedicated staff, or is that one of the many roles or duties that have to be done as necessary? So just finding that out will also help us get a view, a bird's eye view on how communications is done across the state. Next slide, please. So who we actually want to engage. We are hoping that we'll be able to engage a diverse sample of individuals who represent the population of the state of Maryland. And I know that that is something that all of the work groups want to do. So I'm sure we'll all brainstorm on how that should be done. We want to make sure that the questions and response options are relevant for our groups. And so that will definitely, we have to take health literacy into consideration, that we're using the same common language across the board, and then ensure that the groups who typically do not respond to surveys are engaged. We'll talk a little bit more about how that will go in the following slides when we talk about the public. Okay, next slide, please. So here are some potential survey questions that we have for the public. We want to look at a variety of things. The level of reliable internet access, and even what's considered reliable internet access. For example, I know that if my web page doesn't load up within a few seconds, I'm like, what's going on? But for others, it may take them minutes, and that seems fine. So what is that level of comfortableness with accessing information, especially when we're thinking about health information resources? Aside from talking to their healthcare provider, where does the public usually go to find health-related information? We've discussed in our group that we could probably have the fanciest health department website and spend a whole lot of money on that. But if the public is going to another website, perhaps maybe we should pour some money into there, or ask those popular websites to kind of have a link that goes back to our health department website. But just those kind of things we'd like to know. When the individuals are reading health information, what are the things that they're actually looking for? Do they even think about evidence-based? Who's thinking about evidence-based? Does it change by age? Does it change by geographical location? Who are the individuals that they're thinking are giving that important information? What other social media accounts are they looking at? And so we plan to have a list of various social media accounts, and then also an other line, because we may not know all of the social media type ways that individuals are receiving information. And then also, are they aware of the health department's social media accounts, and how often do they go there? Are they even following it? And would they go to their health department for information? Why or why not? Next slide, please. Just a few more questions that we have. Also, in terms of how do they engage with the health department, and how have they engaged in the past, and how would they like to engage with the health departments in the future, and how trustworthy do they find the information? Next slide, please. So also we thought about some outreach for some listening sessions and the ideas that we had behind it. So we wanted to be able to use social media. Hopefully we'll be able to develop some posts and share information about the listening sessions, and encourage members and partner organizations to share this content. And then also using the news media. So the news media concept is a little bit more tricky, but hopefully everyone will be open to it. We're hoping that the commission members or the co-chairs can participate in some news interviews, at least in the local news areas, to talk about the listening sessions, also using print and digital media. And then so that it's not too taxing on the commission members or co-chairs, we would develop some talking points for them to use when communicating with the media. The goal, especially because we are communication and public engagement, is to do our absolute best to make sure that we can figure out communication the best way possible and to get the public as engaged as possible. So that's what we have come up with to date. Open to any questions or suggestions, and our work will continue. Thank you.
Thank you so much. Maura has a hand.
Yes.
Thank you for that great presentation. I'm curious, given Josh's presentation and the discussion about the hospitals and the AHEAD program, would it be, would you consider also putting a survey out to the hospitals, particularly those last 3 questions, right? How do you engage with public health or whatever? I forget what they were, but I'm just curious, given
Well, I think based on Josh's presentation, that would be an excellent idea. I know it adds another layer of work for us, but I think it's really, I think it will pay off in dividends if we do. And I know that our group would be excited about that.
Thank you, Maura. Are there any other questions? Do we have a question from the room? For Sylvette? No? Any question online? No? All right, thank you. Thank you, everyone. Wonderful presentation. Thank you, Sylvette. Thanks to you and the team. All right. All right. Next up is Data and IT Work Group. All right.
Hi, good afternoon, everyone. My name is Jay. I am speaking on behalf of the Data and Information Technology Work Group. I am the co-chair alongside Matt, who I don't think is able to be here with us today.
Jay, I'm so sorry to interrupt. Can you have your tone up a little bit? Just speak louder, if you don't mind.
So this is a team effort. So we do also want to appreciate the support of our CDC Foundation support team, but also especially from our work group, Christina Gray and Donna Peckins, who they're taking the lead for a survey design process. So we are not, can we move to the next slide, please? So we're not really looking to rebuild the wheel here. We're not claiming to be original by any means. So these are the resources that we've been able to identify out there. These are the resources that we're leaning on. So our approach has been to conduct some type of environmental scan, which is kind of how we identified some of these existing resources. So we identify similar work that's been done, adapt just works for our own local context, but also importantly, identify gaps in all of these works and then attempt to fill just gaps. So these are the existing surveys that we're relying on from Indiana, CDC surveys, from NACCHO, but also from the Maryland Public Health Service. They've done some evaluations at the state level, but then also from the PHII. Next slide, please. So as we come up with our survey questions, we're not, we thought it made sense to have some type of guardrails, so having some type of identifying some type of evidence-based framework that would guide our own assessment to development. Again, nothing original about this. This is a paper that was published maybe in 2005 or 2008. We also did not identify it ourselves. This was identified through conversations with the Maryland Department of Health and Public Health Services. So thank you, Nilesh, for also making that connection for us. So I'll talk about this very briefly. And this paper this framework really touches on the development of evaluation tools for health information systems. And you can see 3 main domains up there. So there's the human, there's the organizational, and then there's the technological. And under each of those, you can see subdomains. For our work group, it's still early days, but some of the sample questions that we will ask would cover these subdomains that you see up on that slide. Next slide, please. So who are our targets? So to start with, this would be mixed methods. So it would be a mix of both qualitative and quantitative questions. Off the top of my head, this would primarily be key informant surveys when we develop our questionnaires. But our targets would be leadership and whatever form that leadership takes. So like local health department leadership, so health officers, but then also county level administrators. So people who need data to inform their decision making. We'll also survey frontline data users, super users of existing data information technology systems across the state. And primarily this would be, expectation epidemiologists and data analysts. But then also supporting that work, typically, the technologists, so like database administrators. Would also talk to staff at state agencies, so the Department of Health itself, but then also the State Department of Information Technology that coordinates all IT work across the state. Importantly, we would also be talking to staff at all local health departments. So at the bottom of that page, you have sample questions that we could potentially be asking, and aligned with the organizational evolution framework that I shared previously. We kind of try to fit some of these questions under each of just domains. So under the human, that's questions like I fulfill, asking if people, if survey participants fulfill data requests as part of their day-to-day responsibilities, if they need to share or create data-related products as part of their work, or if they need to conduct data analysis as part of their work and they're unable to do so. Speaking to capacity development issues there, but then also would ask questions that would help elucidate other barriers that keep people from using data. It could also be access issues, but then it could also be just simply access to analysts to conduct the analysis for them. Under the organizational domain, would ask questions like look at things like local health department access to data which they consider useful to them, but then also ask questions that would identify specific data categories that local health departments that they find useful or that they would like to have access to. And then would also ask questions relating to barriers to accessing and obtaining data that they've already identified as useful to them. We would also be asking them questions around leveraging basic data analytics tools, but then also the use of data visualization dashboards to display data. So under the final domain, which would be the technological, would ask about IT challenges, what cybersecurity preparedness looks like for them. But then also we would ask about like an interest in migrating to like a centralized data system. That's something that's come up in some of the conversations we've had in our work group. We would also be asking questions related to IT equipment needs or updates that needed to modernize existing data systems, but also questions related to the existence of an IT strategy and like the IT needs that have been identified previously. Would also ask them to prioritize just needs, and that's about it for our subgroup. The next slide, please. So on for next steps for us, part of how we've been spending our time is breakout sections, to really fine-tune what our goal, what our vision is, but also identify objectives for our work group. Our survey design subcommittee would really get into the process of drafting survey questionnaires, which would work together with the rest of the work group to then finalize and identify targets. Then we'll conduct the assessments, analyze the data, and then start the process of drafting up our assessment findings and draft recommendations. So that's pretty much where we are as a work group. So we welcome questions. Thank you.
Excellent presentation. Thanks to you and your team, Jay. Are there any questions? I see Mina has a hand raised. Thank you, Mina. Go ahead.
Great. Thank you, Jay. That was excellent, and really, really appreciate all the thought that clearly went into thinking of the different, components of technology or data, I guess, and what should be involved in that environmental scan. Thank you. I guess I saw a lot of information and survey questions specifically about data and data access. There were a couple questions that I recall that were about like centralized systems, things like that. How much more would be needed from a technology standpoint, right? And looking at technology that's relevant to the functions of an organization, aside from technology like EHRs or technology that is holding databases, right? So for example, I'm thinking of management systems for like fiscal functions. That's an administrative function of an organization that technology could really facilitate and thereby make the work of the entity much, much more efficient, responsive, timely, et cetera, and also less, labor intensive. So is there a space for the work group to look at how to leverage technology for some of those administrative functions in those health departments?
Yeah, and that's a conversation that our survey subcommittee leads that they've also been able to identify. So for sure, under the technology piece, we will be covering things like that. So we do have the advantage of leaning on the expertise of two individuals who have very deep and extensive knowledge at the local level. So this was actually a conversation that happened in the last say 3 weeks. So good catch there.
Great, thank you. It's the business functions, I guess I was trying to say. So that's very, very great to hear. You'll cover that as well. Thank you.
Thank you, Mina. Are there any other questions? Question from the room or questions? Do we have questions from any of the work group members online, please? All right, you can send your questions in later. I can't think of any right now. Thank you so much. Next is a funding work group, and you have the floor, Dr. Polsky.
All right, thanks. You can advance the slide. I think we only have one. Maybe there's two, I don't know. So we don't have a ton of questions. I guess I'll just read off the slide in case anybody's having trouble seeing it. So first one is what traditional public health funding sources, those would be things like CDC, SAMHSA, EPA. We shouldn't forget that environmental health is part of our greater efforts, CHRC, et cetera, have grants or other resources that are currently underutilized or not being utilized by public health agencies in Maryland. So I think, there are things that we all know that either at the state level or almost all local health departments, we either automatically get because they're non-competitive, but there may be some grants that we really have not paid attention to in the past that could be helpful. And then, so a sub-bullet under that is, can you give specific examples of funding sources that are not being used to their maximum extent? And then below that, do you know of any non-traditional funding sources? And these would be things like private grant organizations, schools of public health endowments, or other funders that can be used for Maryland's public health efforts at either state. And that would include not just MDH, but MDE, DHR, or MSDE, or in addition to state levels, local levels. So not only local health departments, but EMS and other community organizations. So there are some states that have well-established funds. Sometimes it's out of mechanisms that Maryland doesn't have. Like they've had for-profit hospitals that have been taken nonprofit, and as a trade-off for that process, because now they're getting tax benefits, X, Y, and Z, that endowments are set up. Again, that's something that we don't have in Maryland, but there may be other things that people are aware of that we could take advantage of here. So I think there's another slide if you want to advance. Yep. And then so for key groups, I don't think there's really any surprises here. I think maybe the main thing would be the philanthropic organizations in Maryland. I know there's some groups that are more dedicated to Baltimore City efforts. And even though those organizations may not be able or willing under their endowments to extend out to other parts of the state, they may have their own networks and may be available other ways for us to sort of tap into those contents. So that's all we have from our group. Thanks.
Thank you, Dr. Polsky. Does anyone have a question for him or for the work group? Any question in the room? No?
Oh, I have a question.
Oh, yes. Dr. Rochester has a question.
You're muted.
Sorry. I think it was mentioned in one of the previous meetings that you all were going to be meeting with MHA and another representative with regard to hospital funding. I just wanted to follow up on that conversation.
Right. And I didn't mention because my understanding was this was supposed to be specifically about questions for focus groups. So yes, at our last meeting, we had faculty from Johns Hopkins who takes particular interest in community benefits spending, gave a presentation of what happens in Maryland, but also what happens in other states across the country in terms of that. At our meeting this month, we have scheduled 2 representatives from the Maryland Hospital Association to come and give their take on how community benefit dollars are spent and how hospitals partner or potentially partner, whether it's with local health departments or other groups. So I think that'll be an interesting presentation, not only to hear what they have to say, but to be able to ask questions to the representatives from the Maryland Hospital Administration. And then in May, we have people from the HSCRC, not from the board. So Josh was representing the board of the HSCRC, but the actual staff of the HSCRC who oversee community benefit dollars. So I've had some discussions with the staff there in terms of accountability for hospitals. What are the baselines for minimum acceptable spending? Like, you know, there are all sorts of facets to this, including there is no independent means of determining what any given hospital is supposed to spend for community benefit dollars, even though there should be a formula that is developed. So there'd be a lot of, I think, policy recommendations that come out of those kind of discussions. So yeah, we heard the academic this past month. We'll hear from the Hospital Association this month, and then we'll hear from the HSCRC next month. And I think after that presentation, it puts us into a good position to start to consider recommendations as to whether that could be a potential vehicle to partner with public health efforts in a way that to this point hasn't happened. And if so, how that, what the options are as we move forward. So I hope that answered your question.
Yeah, thank you.
Thanks, Dr. Polsky. I have a question. It's regarding measuring equity around funding. How is your work group looking at that?
So we,
across the local department.
Yeah.
Sorry, across the local departments. Yeah.
Yeah, so we haven't focused on that yet. Another presentation that we have at this month's meeting is from the Maryland Department of Health, and that may be one of the things that are incorporated into their presentation. So, you know, we're really trying to be mindful that the public health can't depend just on local efforts, that we need, you know, funding at both state and at local levels. So we may initiate those kind of equity discussions during that. Now that we have unlimited amounts of time with our deadline being pushed back, I think that probably into June, July, we can dig in deeper into equity issues.
Thank you so much. Especially how they align with, health outcomes, right? The metric equity
Right.
outcomes, because, yeah, thank you.
Yeah, and touching back on community benefits,
Yeah.
those are completely absent. There's no the way that things are set up right now. There are no metrics. There's no accountability as far as outcomes. Kind of nothing goes there. So we are focused on trying to align both the money that comes in and then to make sure as best we can that it is used in a way that is really going to achieve some of the outcomes that we want.
Yeah. Thank you so much.
Great, thank you.
Okay, if there are no other questions, we're gonna move on. We have the governance and organizational capability work group. Yep. And that will be presented by Fran. Yes, we'll bring the computer.
Well, that means I have to advance. Okay. So, hey, everybody. Fran Phillips, co-chair of the Governance and Organizational Capabilities Work Group, along with my co-chair, Barbara Bookmeyer, who's on joining us virtually. Michelle Spencer's on the work group. She's in the room with me. Mina's on the work group. I can't tell who else is who's online, who's on the work group, but the work group is amazing and has done a lot of work, as you will see in these slides. And so here's the thing. I don't want to read these slides. You don't want me to read these slides. And I'm not going to read these slides, but Tosin has promised that after this meeting, through the co-chairs, all the co-chairs will get all the slides. Okay, so you'll have all that, right? And then we'll ask the wonderful staff, Shane and his crew, to deconflict, deduplicate, deal with all those slides. Okay, and so I'm just going to we're going to flip through these slides because I have some other slides that I really want to share with you in my allotted time. But suffice it to say that our work group governance is kind of squishy. It's not very quantitative. And so if you look through some of these slides, you will see that we are going to be asking a lot of qualitative questions. Yes, there's some quantitative data sets that the work group would like to. Are you going to help me with this slide? Somebody help me present, because help me advance, would you? Because that would be really helpful.
It's been advanced on the.
Oh, okay. All right, good. Okay, because I don't want to have to deal with that. I just want to get in the zone. Okay. All right. So here's the thing. Yeah, the technology today is a little bit challenging, but we will have some quantitative data sets. We'll look at health officer turnover. We'll look at organizational structures. We'll look at the practices of local boards of health, for example. I'm just going to give you a couple. But as you flip through the slides, you'll see two things. We are asking the same things, the same groups of key informants that other work groups have asked, by and large. We have a couple of additions. We're going to ask elected people, both in the legislature, about what their perceptions are of state and local public health governance. We're also going to ask local county commissioners, county executives, because these are very important people, obviously, who probably didn't run for office thinking that in counties, at least, that they would serve on local boards of health. They do by law. And so we think that they're going to be really important key informants. The nature of our questions have to do with as I said, more subjective, more qualitative data. Can we just flip through these are the slides that you will get emailed. Okay, so I'm not going to go through those. So could you just advance? Advance. Okay, all right. So now I have distilled all of that into these keywords. Look at that. Interaction between, role of, leadership's representation, involvement with, engagement with, partnership, joint cross-sector. So this is all very subjective, but it's very important to really dig down into what's going on in the organization and the governance. Who's in charge, who's making the decisions, who's at the table, and a lot of that has to do with these subjective variables. Next slide, please. So here's a model that I came across. Many of you may be familiar with this. This comes from a landmark paper, Kania, Kramer, and Senge, published in 2018. And I'll give you a reference in a minute. This is a paper, this is a model that attempts to describe system change. What are the elements, the layers that you got to work on if you really want to be successful in transforming systems? And the idea here was to look at why is it that we had the Affordable Care Act and it didn't seem to really transform the healthcare system, right? We've been talking about disparities, equities for a long time, but we're not seeing the transformation yet. What is going on here? So in the view of this model, you've got the top layer that talks about organizations' policies, practices, and the resource flows, whether that's money or information or workforce, right? Those are really important. Those are really important. Not to say that they're not, but that's the surface. That's the structural surface. And certainly that's what our work groups are organized around. Those are the categories of our work groups. But look a little deeper. Look to the next level, which is looking at the relationships between the policies, the practices, and the resource flows. Look at the relationships, the connections, as well as the power dynamics. And this is where a lot of the work really gets, it doesn't show up in any minutes, but this is where things get decided. And then if you look even below that, you see these mental models. Mental models are the things that we carry around with us unconsciously that is really going to bias or frame the way we look at a problem. And when I say we, I mean those of us right here in the room. I don't mean just the external we. It's us in the room, right? So I feel like these 6 conditions for social change are really a good way for us for the next, God, now 3 years, however long we're on this, to look at what do we want to do with public health, and do we want to just focus on the top? Now there's a lot to be fixed and done in that top layer of structural change, but can we go a little deeper and look at the connections, the communication, the relationships, and the power dynamics? Next slide. This is the reference, the citation for that model. Google it. It's great. And there's a webinar, a 1-hour webinar. There's a great paper there, but it starts with this, a little vignette. 2 tropical fish were swimming in the ocean. One fish said to the other fish, "How's the water?" The other fish said, "What's water?" Okay. You probably heard that before. What's water? Okay. We're the fish. Okay. Do we know? Can we see what's invisible? Okay. So you get the idea that we need to look at our own underlying assumptions that we and our mental models that we carry with us every day. Okay, next slide, please. So here's everything that we've done. I'm not going to go through all this, but look at the enormous amount of work that this group of very dedicated experts have done since March. And I mean, this is a heavy lift. I'm not going to read all this slides, but you can see this is what it's exhausting to look at. Okay, but we have accomplished all of this level setting, baseline, introductory work. Okay, we're getting going on. Okay, next slide, please. Okay, what's ahead? All right. So I'm not going to put the timeline on there because Boris just gave us another year to do all this. But thank you, Boris. But we got to do all this stuff. This is a lot of stuff. All right, next slide, please. And so this really characterizes what we've been doing. Okay, we've been super busy, right? Real busy. Why are we real busy? We're real busy because the legislature said, get a group together and figure out how to improve public health in Maryland. What was the underlying message? The underlying message was public health in Maryland isn't as good as it should be, right? It is not optimal. Okay, we still have these persistent health inequities. We have behavioral and substance abuse crises. We have a pandemic. All of that opened up Pandora's box to say that public health is shaky. It's weak and it's shaky. And it's got to be better to meet the challenges today and in the future. All right, modernization. All right, what is modernization? Yeah, we got to do all the organization, IT, data, funding, but we got to get deeper than that. We've got to look at the power dynamics, and I think we touched on some of that today. In a lot of the discussions, we're touching on the power dynamics that really bring us a cultural change and a system change. Next slide, please. So we are not alone in this. This is, I think this is last December's issue of American Journal of Public Health. This is a national phenomenon that public health around the country is saying, wait a minute. This is not your grandmother's public health anymore. We have got to do better than this. We've got to step up and meet these challenges. Next slide. So now this is for us. This is for our commission. We're busy. We're so busy doing all this stuff. Where are we going? Like, what is the deal? What is the goal? What is it that we want public health to be in 2025, I guess, when we're done and beyond? What is it beyond fixing the weaknesses, identifying the gaps, filling the holes? Is that going to get us to where is that the future? Is that what we're aiming for? Is that what we want? And I'm going to ask you to think that that's probably not all we want to do, right? We want to envision a public health structure in this state that is structurally improved. We got to do that, structurally improved. But it also has to deal with the power dynamics and the inequities that continue in this state. And how can we make that better? And we won't get there if we sit and if we don't get out of our comfort zone and go talk to people who we don't talk to, and they certainly aren't going to come and talk to us, right? So we need to rethink some of the mental models. Mental model used to be, oh, I'm public health, I'm pure. People in the hospitals, they're all money grubbing, they're out for money. Okay, I'm pure, I'm teaching people prevention. They're all sick here. Well, we got forget all of that. Okay, we need to get into spaces where we haven't been if we're going to be successful in the future. Next slide, please. All right, I'm rounding it out here. Okay, I'm going to give you some possible principles, maybe. So this is an outline, and this is totally subjective. This is from Fran, and that's an N of 1. We need to invest as a group in looking at what do we want to do? What do we want at the end of the day? What do we want this commission to write in a report beyond how to fix all the things that we know are wrong? Okay, what is the dream that we want to outline for the future of public health? And I'm going to say that, yeah, the first one is a non-negotiable. We want to assure conditions in which Marylanders can thrive. Okay, prioritize. We need to focus on fixing this structural racism, because if we don't, it won't change. And so unless we in public health put that first and foremost, it is going to be business as usual. State and local health departments have to, I don't say they have to love each other, but we got to talk more. We got to collaborate more. And I don't mean just MDH. I mean across all the state. I mean the Department of the Environment. And I also mean HSCRC, that commission, HSCRC. Okay, that's a state commission. All right. We need to really expand our horizon on how we can develop collaboration that is going to change culture, and not just our culture, it's going to change their culture. They're going to get better by virtue of having exposure to public health. And then the last thing is, yeah, governmental public health is always going to be different because we have accountability to the public that the health systems, the health plans don't have. They have accountability to their board of directors, but we have a broader transparency requirement. And that puts another layer of responsibility on us. But that's something, again, that we can take to the healthcare system and say, we are the government, we are the accountable people who represent everyone in your catchment area or in your enrollment. And so it's a larger ecosystem that we need to be part of. But if we continue to be as insular as sometimes we have been in the past, we're going to continue to miss the water. We're going to be swimming and we're not going to know what it is that we're swimming in. So I totally went rogue on this presentation, okay, with the generous agreement of Tosin to allow me to do that. You can read all the slides you want, but I really wanted to infuse, to step it up a little bit so that we can look ahead. We're still going to be busy, but look ahead in some very meaningful ways, I hope. So I'm happy to take any questions, but thank you. Yes.
All right, you have a lot of thumbs up in the room. Thank you. That was excellent. There's no doubt. Mina has a hand raised. Mina, please go ahead.
I was just going to say, Fran, that was quite a rallying cry, and just very, very well put, and appreciate all the thinking about this broader vision that we really need for the whole state, and the importance of keeping our eye on that bigger purpose and broader vision. Thank you.
Yeah, it's not the same. I know that everyone on the commission has had these thoughts, and I know some of it has been brought up in discussion today and by the other work groups' presentations. And so I just felt it was time to start, distilling that and actually giving this stuff names. I think that model is a really simple model, but it really, I feel, may have some value as guiding us in the future. So,
thank you, Fran. There's no doubt we're on the right path to reducing disparities in the state.
But also just a question, not quite so much as a comment to Fran, and it goes back to something that Josh talked about, which I think to a large extent from the commission's perspective, right? it's strange, you know, that we think about, okay, these recommendations that we're going to come up with, right? And that is, you know, the final goal is all going to be sort of short-term things. So these are the quick fixes. I think what you've really brought to light, and Josh sort of reaffirmed this, that it can't just be that, right? And so we do have to stick our necks out, which is, okay, we're going to push the shorter things to change tomorrow, right? But, you know, we also have to look at this as the longer game, right? And part of it is, you don't shift, you know, cultures overnight. You don't have people who aren't used to talking to each other just like that. We can't just put them in the room saying, talk with each other. It is going to be this blending in, but I think we need to be bold from a commission's perspective, which is, you know, this is what needs to get done. And these are the steps to get there, right? Because part of it is we can't just be aspirational saying, okay, 20 years from now, we want to change the world. The reality is we should roadmap this out, right? Which is, here's who needs to start talking with each other. Here's who, and from a governance perspective, here's who needs to start making decisions together and not independently in silos.
It might be worth thinking about, and I don't know much about systems change, but there's a body of knowledge and there are people that could do a presentation for us on these fellows or whoever, to get us a little bit more coaching on how to tackle intentional system change and culture change. Because you can't, one person can't do it. You have to get a coalition. There's a very strategic way to approach it.
Thank you. Sounds like, you know, systems thinking approach will be what's well. All right. We now have the workforce work group. Can we please advance the slide? So we have the workforce work group. We're giving the, oh, sure. Please take your time. Yeah. And that will be the final work group to give their presentation.
And that is a very hard presentation to follow. I'm not going to have that much passion. I'm sorry.
We hear you, Sue. We hear you.
But I'm going to do my best. So the workforce work group's been working to use the NACCHO local health department profile to gather data on all of the local health departments. We originally thought that was not going to be an option, but we've since found that we do have at least 91% of the health departments participated. I think there were 2 that did not complete the survey. And then we're going to be suggesting that we use the 2024 Public Health Wins data to put together a full picture of the Maryland workforce. The DuBont Foundation is working with its contacts at NACCHO to access the data, and they're hoping to have that data as early as summer. The DuBont Foundation is deploying the PH Wins in September of this year, and we're going to be working with local contacts to monitor the survey. So part of what the team is trying to put together is that DuBont is going to be checking with the research evaluation learning team to see if it's possible that we could share the survey ahead of deployment to increase the quality of responses. They're going to be working with the local health officers and the state health department on making sure that we're monitoring, what's going on in the responses that we're getting. They're going to be working closely with Ruth from NACCHO and Vanessa from MDH to prep all of the staff members on talking points, one-pagers, optional webinars, and getting accurate timeframes requirements for the survey. Apparently, they say it takes 15 to 30 minutes, but it may take longer, so we're asking for transparency in that, how long it's going to take. As a side note, any health department that's FAB accredited under domain 8, this survey, the PH Wins, will count as a workforce survey for you. So we thought that was a good talking point to share. And let's see. Okay, at the point where we're working on getting the survey out and making sure that we have accurate timeframes, we're also going to have some increased work group involvement to encourage participation and do some messaging and sending reminders to our colleagues. Parallel to the data collection, the DuBont Foundation, the work group interns are going to be creating table shelves and a draft report. While the data will not be available until January of 2025, once it's cleaned, we can simply plug and play the results. The results will be the basis of the recommendations for the working group to put forth to the larger commission. I also know that the DuBont Foundation is going to be prioritizing the Maryland data. They have committed to that, so that once the survey goes out nationally, they will be pulling our data first to keep us in line with the commission. And that's all we've got. Happy to take questions, but I think Bob and Bethany are on also, so they can help me.
Sure. So Mina has a hand raised. Yeah.
Thank you. I appreciate that update, Sue, and all the work that the Workforce Work Group has been doing. And just a shout out and thank you to the De Beaumont Foundation for their willingness to be so involved and responsive to Maryland's need for assessing our public health infrastructure. I did, one of the questions also was about the NACCHO survey. You'd mentioned before that it wasn't going to be possible, I think, to get, what were you saying, that it wasn't possible to get NACCHO's information?
Originally, Brian had reported that there were only 2 health departments that completed the local health department profile survey, but Ruth went back to him and said, no, all of the health departments except maybe 2 did it. So they are currently trying to pull that data from NACCHO. Brian has a request in for that information, and they'll be able to put together a very comprehensive look at least what our profiles are, what we do, our structures, things like that, to compare ourselves.
Okay. The other point was something that's come up in prior meetings of the commission, is that Maryland's public health workforce is quite diverse in its specialties and disciplines represented, right? I mean, we are like super agencies, both at the state level and the local level, in terms of the work that we're doing, from environmental health inspectors to behavioral health workforce to nursing and everything in between, and all over the spectrum, to do that wide variety of service that we provide to our communities. So the workforce work group assessments, as they're developed, will they be inclusive of that diverse workforce at the local level? And then also at the state level, will the workforce assessment relevant to the state public health workforce include non-MDH entities like MDE, or is there a desire to include non-MDH entities like MDE, because of course they are very relevant to the local public health workforce?
All really good questions. And as you know, I'm new to the committee and new to this position. I don't know if Bethany can answer any of that. She did say they received the instrument and they're waiting for the data to be released. But I can take that back to the group and ask. I know. Go ahead.
Go ahead, Sue. Sorry.
No, I was just finishing up. I was going to write the questions down, so I remembered them.
Mina, those are great questions, and I can answer them a little bit, but I do think that it's something worth exploring. The PHWINS instrument, as it stands right now, is in its pretty much final form, as it's been worked on, for the past 3 years, to update it from its previous instrument to this new one. And because we're going to be deploying it in the summer, I think we're in the kind of in the early fall. We're going to be deploying it in the early fall. I think we're in a tight timeline to get any additions added to PHWINS. Now, that doesn't mean that we can't ask additional questions, like you're saying, that would be specific to Maryland, but I do think that they would have to exist outside of the PHWINS instrument. Now, that doesn't mean they can't be deployed at the same time we deploy the PHWINS instrument in you guys' health department. So they can look like one survey all to each staff member. And that's definitely something we can explore, but we can't integrate it, I don't believe at this point, into the PHWINS survey. So definitely something for us to think about. I think at this point, it's a timing issue. So if we want something to get out with PHWNs, and sort of a quote unquote like Maryland supplement, we would need to kind of get on that to make sure that we're being inclusive. One of the other things I wanted to add is we're doing a crosswalk. I mean, I can include this update too. I know that some health departments have workplace surveys, and we're going to try and collect as many of those as we can to do a crosswalk between those surveys and PHWNs to see what questions we're capturing in PHWNs already. The wording of the questions as you have them, because you guys work in these settings, so you know what kind of lands for your staff over others. So we're going to work on these kind of crosswalks of existing surveys, but definitely we'll need you guys' help on that one to send us anything that you guys have that exists, and then we'll compare against PHWNs. Does that sort of get at what you were asking?
Absolutely. Thank you. And so the next part is the piece about the state is what, how are we including the state public health workforce in all this work?
That's a great question. It's something that we'll have to discuss, I think, with our REL for De Beaumont, stands for Research Evaluation and Learning Team. I think it's something we'll have to discuss with our REL team to kind of see how they've done a breakdown like this before. You know, other states are set up in a similar structure to you all, but this is the first year that we're including local health departments in PHWNs. And so I know that they've spent a lot of time kind of answering this question about how to make sure we're getting representation from both state and locals, and then what the threshold for state and locals is as well. And so they are much more versed in the PHWNs instrument, and I'm just being a proxy right now and speaking on their behalf. But we'll definitely work with the work group and take these questions back. I do know that we're having a meeting with them tomorrow, and we do hope to invite our research evaluation and learning team into our workforce work group. And it's even maybe something we can invite them to the next monthly meeting here to hear from them directly as well, since we're going to kind of need to deploy WINs broadly across the state.
Thank you.
Thank you, Mina.
Thank you both. Are there any other questions? Do we have a question online or in the room? For the workforce group? No? I'm saying none? All right. We're getting to the tail end of the day. Now next announcement. Okay, we're good. Sorry about that. So let's go over some announcements. Our next meeting will be on May 2nd, from 2 to 5, hybrid, as usual. And we'll have a virtual option. We'll be disseminating the materials, as we always do. Upcoming is the Southern Maryland Regional Public Listening Session on April 16th at 5 p.m. at St. Mary's County Government Center. Mina, do you want to touch on that? Just, final touches?
Yep, nothing really beyond what we said before. Just, this is going to be a listening session, so it's set up to be as like a hearing would be. For people there in person, they will be able to give comments. And for people online, there'll be an online mechanism to submit comments that will be considered after the hearing date. Thank you.
Thank you, Mina. All righty. Oh, okay. Nicole has a question.
That being publicized.
Oh.
Sorry, if that question was for me, I didn't hear it.
She said, how is it being publicized?
So we'll start with like a press release, essentially, social media, and then out through partner networks that share that information. The 3 Southern Maryland health departments will collaborate on getting it out to their jurisdictions.
Thank you so much, Mina. Now on to the last item on the agenda. Can I please get a motion to adjourn the meeting? Oh, you move? Okay, Nicole moves. Can I get a second, please? All right. Okay. Thank you, Michelle. Michelle seconds. Okay. All in favor, say aye. All right. Any nays? Anybody want to stay here? Yeah. Any abstentions? And I'm also looking at the room. All right. Thank you so much, everyone. For the record, the meeting was concluded at 4:42 p.m. Thank you so much. We really value your contributions. Thanks everyone for joining today. We hope to see you next time. Thank you.
Thank
All
you.
right. All right. Thank you. Bye-bye.
Thanks.